Dear Dr. Li, Dr. Han, and Dr. Haider, I'm so honored to be invited to join this China-Pakistan Nuclear Medicine Conference. And today, I'd like to talk about the management of radioiodine refractory differentiated thyroid cancer. I'm Dr. Lin from Peking Union Medical College Hospital. And my topic today would be three parts. So first, let's take a look at RAI refractory differentiated thyroid cancer. Thyroid cancer has been paying more attention over the recent years because of its globally gradually increasing incidence. And nowadays in China, according to the Journal of National Cancer Center, thyroid cancer is the third more common and prevalent cancer among Chinese women. Though it has generally accepted that thyroid cancer has a quite favorable prognosis, with a 5-year survival rate over 98%, but it was just according to sheer database. However, in China, this figure was less than 85%, with a 14% of disparity between China and other developed countries. We realize that we may encounter more patients with advanced stage and life threatened. So this is what we have focused over the recent years. Differentiated thyroid carcinoma DTC, which primarily comprised by papillary and follicular thyroid cancer, accounting for more than 94% of thyroid carcinoma, owing to its specific features, such as keep the ability of iodine uptake and keep the ability to produce thyroglobulin Tg and keep the response to TSH thyrotropin. So surgery, radioactive iodine therapy, TSH suppressive therapy, has been recommended as the first-line therapy for intermediate, especially the high-risk and metastatic DTC. We're so happy to see such patient with FTC and distant metastasis after several times RAI therapy, along with the decrease of the lesion over their pulmonary area. Their tumor marker, Tg, keep decreasing. It means it has a good response to RAI therapy. However, sometimes we may encounter such cases with the lesions keep enlarging, which can be monitored by chest CT, but they no longer uptake iodine, with the Tg level keep rising. If the patients can afford an expensive FDG PET, we can visualize these rare DTC lesions with high glucose metabolism. And up to 15% of DTC with persistent or recurrence disease, and up to 1/4 of the patient would eventually develop to distant metastasis. And about 2/3 of this patient would eventually become rare DTC, even after several times RAI therapy. And we know that the uptake of radioactive iodine over their metastatic or recurrent lesions is an independent indicator for survival. And from the statistic, we learned that if the patient cannot, with their distant metastatic lesions, no longer uptake radioactive iodine, the 10-year survival rate would be less than 10% in comparison to those whose distant lesions with RAI avidity. And rare DTC was first related by the American Thyroid Association guideline in 2006. It can be characterized as 4 scenarios, with either tumor does not ever concentrate RAI after successful remnant ablation, or tumor loses the ability to concentrate RAI after previous evidence of RAI avidness, or the RAI is concentrated in some lesions but not others, or the metastatic disease progresses despite significant concentration of RAI. Once the patient was identified as rare DTC, then according to the different guidelines, which mainly consist of ATA guideline, NCCN, or even Chinese Society of Clinical Oncologists, CSCO, we should stop RAI therapy with active surveillance for some stable disease patient. And once the disease becomes symptomatic or progressive, we should initiate local or systematic therapy. Well, we can see controversies over the defining of rare remain exist and primarily raised by our nuclear medicine physician, like the current definition of rare are suboptimal and do not represent definitive criteria to mandate whether or not RAI should be recommended. And no current definitions classifications is an absolute indicator that a patient has rare, and be cautious to label a patient as rare. It can just convey the likelihood that a tumor will be refractory to additional RAI therapy, and the criteria of rare will continue to evolve as the improvement of imaging techniques and redifferentiated therapy, which can enhance the effectiveness of RAI therapy. So this is the first part. Let's go to the management of rare. First, how to identify it. Well, a rare DTC can be diagnosed by integrating their clinical history and the iodine uptake over their lesions, and also the change of TG serologically, and also the lesions change radiographically, or even by FDG PET, which all seems a little bit time consuming. Apart from the mismatch of iodine and FDG imaging, which recommended by different guidelines, in China we also use MIBI scan to locate the rare DTC lesions. And also we can use integrin imaging in identify rare DTC. These are the work we have done around 2012, which has been published on the Journal of Nuclear Medicine. We can see the RGD uptake over the pulmonary lesions, and its uptake show good correlation shape with the tumor's growth. So in this way, the integrin imaging, which can reflect the tumor angiogenesis, could be used to localize the rare lesion, and it can also afford the basis for the subsequent anti-angiogenic treatment. And around 2013, we also explored the association between BRAF mutation and their in vivo RAI uptake in metastatic lesions. We can see BRAF mutation was harbored in their primary tumor in 26% of the patients. And if the patient harbored with BRAF mutation, then nearly 84% of the patient in their distant metastasis tends to be radioiodine refractory. And for patients with no BRAF mutation, more than 94% of this patient would present radioiodine avidity. So in this way, we learn that BRAF mutation may drive the early identification of non-RAI avidity in this distant metastatic DTC. And around 2016, we also explored the synergistic effect of BRAF and TERT promoter mutation on the in vivo RAI uptake in metastatic lesions. We can see the co-mutation occurred in 15% of this cohort. And if patients suffer with TERT mutation or the co-mutation, their distant lesions tends to be RAI refractory. And also, all these patients, even after RAI therapy, their TG level keep increasing. And here is the example. If the patient harbored with neither BRAF or TERT mutation, then along with the decrease of the RAI uptake, their TG levels keep decreasing, means RAI responsive. If the patient harbored with BRAF and TERT mutation, then they will initially present with RAI no uptake or non-avidness, and their TG levels keep increasing. So in this way, we learn that BRAF and TERT promoter mutation drives the early identification of non-radioiodine avidity in their distant lesion. And we can use simplified quantitative seroglobulin response to identify this rare DTC, even though we have no molecular imaging method mentioned above. And here is the paper we published around 2017, which I won't go to any detail. So in this way, we know that we have many methods to identify the rare DTC, and molecular features reflected by the molecular imaging and genetic background would be helpful for early identifying rare DTC and avoid unnecessary repeated RS treatment, which would otherwise aggravate the disease condition by the TSH stimulation. And we would go to the third part, treatment. Hopefully, as one of the hypervascular tumors, since 2007, some classical anti-angiogenic targeted drugs have been explored as the new option for rare DTC. These are the two milestones for rare DTC. In decision trial, sorafenib demonstrated a 5 months progression-free survival over the placebo, which allows its FDA approval in 2013. And in select study, lenvatinib demonstrated an even impressive progression-free survival of nearly 14 months, which allows its finally FDA approval in 2015. However, in China, only in 2017 and 2020, sorafenib and lenvatinib was finally approved by the CFDA, or nowadays we call it NMPA. So before that, there is a great unmet need for rare DTC patients in China. And because the China has not been involved in the SELECT trial, so we have to initiate another study 308, a phase 3 study of lenvatinib in rare DTC in China, which we have finished last year. And we can see the study 308 demonstrated even more impressive median progression-free survival as nearly 24 months in comparison to the placebo, 3.7 months. And we can see all subgroup analysis, all the subgroup benefit from lenvatinib. And we noticed that when there was no available TKI in this period, some domestic Chinese products like apatinib, anlotinib, donafinib has been investigated by the Chinese investigators. Let's take the reality study of apatinib in rare DTC as an example, which I am so honored to be the leading PI in China. The primary study endpoint was progression-free survival, and the secondary study endpoint was overall survival. And the study was designed quite similar as lenvatinib in their SELECT study. Apatinib demonstrates a prolonged progression-free survival benefit as 22.2 months in comparison to their placebo, 4.4 months. Moreover, apatinib demonstrates the OS benefit in comparison to the 29.9 months in their placebo, but not yet available in apatinib group. So all these studies move the treatment strategies of rare DTC from the chemotherapy to angiogenesis MKI therapy. And along with the development of precision therapy, in addition to this classic angiogenic targeted therapy for VEGFR, FGFR, and PDGFR, some specific target inhibitors for RET alteration and NTRK alterations have been explored for rare DTC. Let's take Liberto study as an example. In this study, they mainly explore the safety and efficacy of sulfatinib in RET-altered tumor, in which we can see 27 rare DTC patients with RET fusion were enrolled. And sulfatinib displayed an impressive overall response rate of nearly 80%. And we can see patients with brain metastasis benefit from this study. In comparison to those multi-kinase inhibitor, this specific targeted therapy displayed less adverse event. And this is the NTRK fusion studies, which demonstrate an even better overall response rate. And also, inhibitors focus on PD-1 also demonstrate impressive efficacy. All this study leads to approval and recommendation of these drugs in rare DTC in different guidelines, such as NCCN guideline. So in this way, from the multiple targeted angiogenesis MKI therapy, the treatment strategy of rare moved to specific target KI therapy and immunotherapy. So we may still remember that we were encouraged by this slamtinib reversed iodine uptake of rare DTC, which published in New England Medical Journal in 2013. But unfortunately, we cannot see the further report on its phase 3 study. And more recently, another case study published in this great journal encouraged us again, which untracked targeted therapy in enhancing RAI reuptake, which shed light again on the RAI plus style. And also, as time limited, I cannot go to any detail. We can see the immunomodulatory activity as some angiogenic kinase inhibitor like lenvatinib allows us to the combination of kinase inhibitor and PD-1 and PD-L1 study. So recently, we can see some add-on study such as pembrolizumab salvage add-on therapy on patients with rare witch resistance to the first-line lenvatinib. So, and we realized that upon progression of patients suffered from rare, decision-making would be more challenging and should be shared between patients and multidisciplinary caregivers. Many factors should be taken into account, like tumor size burden, growth rate, size, and key drivers of rare morbidity and mortality, along with the current and projected tumor-related symptomatology, comorbidities, and performance status. And the patient's benefit versus the risk is always what we should balance. The key challenging problems would be when to start the TKI, that means the timing, which would be the first line, the dose, and what's next after resistant to the first line TKI. Well, to summarize my topic, the 5-year survival rate of thyroid cancer in China is still lower than that of the developed country. And imaging methods other than FDG PET and molecular features could be used as indicator for early identifying rare. MKI targeted angiogenic therapy has been the first-line targeted therapy for rare, and new molecular targeted therapy, more specifically on RET, NTRK, and immunotherapy, brings the new hope to patients. And some other combination therapy shed lights on the new aspects for these patients. Well, thank you for your attention and welcome to Peking Union Medical College Hospital. Thank you.